Okay, because we start a little bit earlier because the outside traffic is very bad. So we start the practice about 8:30. But don't worry, we will repeat the practice again. Okay, and when you come to this room, you found some people already changed the preset of the device. Today we are going to introduce the imaging about the nerve. If you are looking at the superficial nerve, you need to have a very high resolution ultrasound probe. But as I said, the most important thing is here, not the device. And my colleague, my PD colleague, often asks me one question. We don't have an ultrasound. And I said, the problem is you don't have an ultrasound. The problem is what you are going to do with your ultrasound. Okay. Today this conference is supported by Ultrasound Devices company. The probe we got, I think you noticed, the best range is about 1 centimeter to 3.5 centimeters depth. We are going to look at the median nerve. It's a hot topic for clinic and also for research. The depth is about 0.3 to 0.5 millimeters from the skin. So what will you do? Call the company and give them some more money to buy a new probe? Or like me, rob my colleague and get a new probe? Or borrow a probe without paying any money? That's another style of mine. No. We are going to put some more jelly on the skin. So let us review the basic skill of the probe, holding the probe. The first one, sliding, right? Sliding, right? Probe sliding. The second is tilting, right? Tilting. Slide to your position you want over the anatomy. To find the anatomy structures you want, slide. Tilting to find the best angle. Then rotate if you need. Heel lifting to find the best quality imaging, right? Heel walking to find the next one, right? 5. Compression to see the tail side and the tenderness point. The 7th, floating. Floating I cannot show. I'm not magician. Okay. You know all 7 basic skills. That's very rare for me because I always teach 4 basic skills in one day or 2 days class. This time is the first time I need to introduce all the 7 skills in a very short time. Okay. Slide, right? Tilting, rotate, heel lifting, toe skill, compress, floating. Remember? Okay. I don't think you will forget it. Okay. 7 skill. If you discuss the basic skill with your colleague and you forget the name, right? You just show them sliding, tilting, rotate, and they think you are crazy after the 3 days class. Okay. We are going to discuss the knee but we have some basic knowledge about the nerve are also included in today's class. Yesterday, I think you used the caliper to measure the thickness of the muscle, right? Have you measured the thickness? No. Today, you are going to measure the thickness of the nerve. Use the measurement tool, because the thickness in the area of the nerve is very important to make a diagnosis or to find the variation or pathological change. Okay. With a high-resolution ultrasound, you can see a nerve like this one, right? This table, right? There was a lady. Yeah, her median nerve is very good. Looks like this one, right? Dark hole, right? Bright outer layer, but dark hole inside. If you change to transverse view, it's like this. Okay, but the tendon is bright, right? And all the way. Okay. So the brightness in the nerve represent the epineuron and the perineuron. The endoneurium show hypoechoic in ultrasound. Okay. If you use a 10 megahertz probe, the diameter will be, the size of the imaging will be very small. So it looks like tendon, because the hypoechoic area is reduced. So the distance between the bright line is decreased. So it looks like tendon. So that's why a lot of people have problems to differentiate the nerve and the tendon. But do not worry, because the tendon is so organized. So if you lost the correct angles when you look at the tendon will become dark, hypoechoic very quickly, disappear, gone. But nerve still keep its shape and the textures. Okay, so we will practice that again. But did you notice we changed the preset? We changed the preset to nerve or small part. Either way is okay. Either way is okay. But this table still use MSK, so I think there are some technique problems in here, but it's all right. And I will check the preset in each tables, so don't worry about that during the practice. Okay, I think someone in this table already saw the texture of the nerve, right? The honeycomb, this one. I think did you? Okay. Okay. If you do not have any, if you are late, so don't worry, I will demonstrate again and just look at the TV, okay? And you can help me to be the subject. And you can help me to point out the ulnar artery and the median nerve. Yeah. So listen to him. Yeah, I will do the job. Using the floating scale, explain for me, either in Thai or English. Oh, yeah. So I'm using a lot of gel to increase the distance between the skin and the probe, and use this way as the medial side, ulnar side, to find the ulnar artery. Find the other artery, find the retinaculum. Find the retinaculum, find the medial nerve. Okay, I'm tilting the probe. See the bright side, bright spots? That they are tendons. Okay, tendons, 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 tendons. Okay, there is a structures. There is a structures. When I change the probe angle, it is still there. Which one? These are tendons, right? Which one is still there? This one's still there, right? Sorry. Can you show them to me? Can you show these to them? Okay, I'm going to do it again. Still there, right?
ตรงเนี้ยครับ
Tendon.
คือภาพขึ้นจอมันอาจจะไม่ชัดเหมือนกับที่เครื่องอะแต่ว่ามันอยู่ตรงเนี้ยครับเนิร์ฟ
Okay. See the cell? Okay. Oh, okay. Thank you very much. But this is more clear, right? There are some. Yeah. Thank you. It's 1, 2, 3. Yeah. Thank you. Yeah. 1, 2, 3, 4, 5. But it's more clear in here. Yeah, it's more clear in here. So we need to find the structure with the cell, like the honeycomb. This is the tendon. This is the tendon. Okay. The same. In 14 scale. freeze for me, please, someone. Gentlemen, gentlemen, gentlemen. Okay, thank you very much. I did my best. This is nerve, right? This is nerve, see? This is nerve. 3 million bar. 30 million bar. Oh, sorry. It's 3,000 bar. 3,000 bar. 3 million bar. 3,000 bar. Sorry. 300,000 bar. 3 million bar. Yeah. The most important is, come on, do it. Floating scale. If you cannot do it, that's it. It's all right. But if you can do it, you have a brain worth than more than 3 million bar. Okay. Floating scale. Turning 90 degree. Rotate. That's the tendon. Oh, so 1 minute. That's the fiber of the tendon. Okay, the fiber are highly impacted. So the dark line, the distance in the tendon is very small, narrow. In the nerve, the distance between the bright line is very big, obvious. So if someone come to me, say, Professor Wang, can you recommend or give our device some suggestions? Sometimes I use median nerve because this is a 3 structure level. 1, 2, 3. Median nerve, superficial, profundus. 3,000 bar. Okay. I often use 3 million bar. Yes. Thank you very much. Do this. If you can do this, your brain is much more worse than 3 million bar. Come on. I'll give you 10 minutes. The guy, he is strong, deep. I cannot reduce. Well, here is the median nerve, but it's very close. Good. Freeze. It's not you. So you see the 3 layers, right? Okay. Make him do it again. Don't worry. They are late in the mosque this morning. She's late. She was late, right? Okay. Tell her. Yeah. Floating scale. If you want to see if you want to remember one thing and one thing only, remember the imaging. Okay. When I ask my kids, my 5-year-old kids, I say, tell me your feeling about these pictures, and tell me what you are looking at. And my kids tell me, it looks like straw for drinking in the longitudinal view. And I asked my daughter, Tell me, what are you looking at? She told me some ladies use very long comb, right, to fix their hairstyle. Yeah, and she said, "These looks like the teeth of the comb, right?" Okay, and I tell him, and I show the tendon to them. Longitudinal view. What are you looking at? Brush. Hey, so you can remember now. Okay, if we are talking about the tendon texture, brush, a lot of fibers, very dense. If we are looking at the texture of the nerve, straw, or the I don't know the name in Thai is the bee. So there is something like that. Really, I thought my daughter is making fun of me. Is to fix the hairstyle, right? For the ladies, teeth. It really is a bee. Okay. So next time, if you are looking for someone to ask, is this tendon? Look at first, like a bee or not. If you like brush, tendon. Okay, right. So it's hypoechoic inside. The distance between the teeth of the bee is very big. In the tendon, the distance between the tendon fascicle is very small. It's very dense. So, and from the echo imaging, we know the echo mainly came from the peri and the epineuron. So basically, the endoneuron looks like does not generate echo intensity very much. Okay, so that's the normal imaging of the nerve. But there are some neurological change become hypo, totally echoic. Yeah, so demyelinations. Yeah, okay. Cool. So if there are some blood flow surrounding the nerve, and they are not normal blood vessel, that means the neuritis, the nerve inflammations. Okay. This is the median nerve you are looking at this morning. And sometimes I check the quality of my ultrasound device with looking at the ulnar nerve in the Guillaume tunnel. Yeah, Guillaume tunnel. Guillaume tunnel is about 1 centimeter depth, but the texture need to be, the texture is very difficult to observe. So I check the quality of ultrasound by looking at the ulnar nerve. So it's something like a joke. 3 million baht, 5 million baht. Yeah. Neuromuscular cutaneous nerve is very easy. It's very easy, but there are some more easy nerve we can show you later. It's here. Yeah, it's a Mickey Mouse. It's brachial artery, ulnar nerve, medial nerve. Yeah, it's easy to find. I will show you later. Yeah. Okay, so don't be panic. The nerve looks differently in the ultrasound. They have their own profile. So, but basically, they all got this imaging profile. So this is most important imaging that you need to remember for the nerve. Okay? If there are some fluid or hypoechoic surrounding the nerve, look at the entrapment sign. Swelling, narrowing, impingement. Okay. The nerve swelling, narrowing, right? Narrowing, impingement. So if you look at the nerve and you found they are swelling, narrowing, and it indicates the nerve is impinging here. Okay? And reduce the pressure or the impingement is very important for the treatment. Swelling, narrowing, impingement. Okay. And also the become hypoechoic. Hypoechoic is an indication. Hypoechoic of nerve is an indication of nerve demyelinations. Okay. And when I was young, I get my first ultrasound device, and in about 20 years, about 20 years ago, there's a discussion about the nerve impingement. Should nerve impingement cause nerve swelling or nerve narrowing? Theoretically, impinge, compress should decrease the diameter. In clinic, we observe swollen nerve, diameter increased. So, research report, if nerve is impinged, the diameter increased. Come on, does not make sense at all. Something is nonsense in report, but I told my colleague, I don't believe this. So we decide to look at the acute effect of the nerve compression. Okay, did you know that the oculotherapists they ask the hemiplegic patient to push on the sliding bowl, right? Right? Okay. And because the hemi side is so weak, the patient cannot hold the bar, so they wrap it, right? I don't know. 20 years ago in Taiwan, yeah. So I think the wrapping and the compressions of the pushing bar compress the medial nerve. And I write a proposal. I say, I just stay with the occupational therapy department and look at the diameter, the medial nerve diameter before and after they're doing the exercise, and also carry out nerve conduction velocities. And I found the nerve conduction velocity immediately reduced after the exercise. And the diameter reduced, the diameter increased, but the height, the thickness reduced. The thickness reduced, the diameter increased. So it looks like the nerve is compressed. So my study is very lucky to get published. And more study look at the acute effect. And then the conclusion is the place where get impinged, get narrow. But the distal side, where close to the impinged side, gets swollen. Okay, gets swollen. So this conclusion leads to another big impact to the treatment. Find out the places of impingement and decompress the nerve. Okay. Right. Okay. So bone is very easy. So if your colleague are interested in the bone lesions, we often look at the cortex line. Okay, so yesterday we look at the cortex line of the human head, right? If there is a discontinuity and huge gap, it's a lesion like heel suck, is a sign of anterior dislocations. In the tibia bone, femur bone, or any bone, long bone, if there is a discontinuity and there is a gap, it's a signal of fracture. So if we are looking at the bone and the joint, we look at the continuity of the bone cortex line first. Okay. Synovium. There are a lot of synovium surrounding the joint and the tendon. If you use B mode and found swollen joint or swollen tendons, you can use power Doppler to check the distribution of vessel is normal or not. If there are hypervascularization surrounding the tendon or surrounding the joint, is an indication of a synovitis or arthritis. Okay, but I think I need to point out again, my point of view is not using ultrasound to make diagnosis, but to help our treatment strategy. Okay, so in this case, we need to use modality or treatment to reduce the inflammation. Okay, according to your experiences, what is the best strategy to reduce inflammation for your point of view? Ice is good, but ice is for superficial, right? So any strategy for reduce the inflammations. Sorry? Ultrasound therapy, okay. With the pass mode, right? Not continue, yeah, passed, okay. But some study does not show it is effective, yeah. Okay, so my point of view is you are very young. There are a lot of young staff here. Find out a solution for reduce the inflammation in deep structures. Yeah, that will create a huge opportunity for the future of physical therapy. Yes. Okay. Because in my clinical services, if I find any cases like this, I will check their medications. Do they follow the medications? The doctor's prescriptions. Did they took the medicine? Yes. If they did, and their compliance is very good, I will report to my colleague. Maybe they should adjust the dosage of the medications, because in this kind of condition, it's not good for exercise, from my point of view. So, I know you can direct access the patient in time. So, another advantage for you to use ultrasound is select the right patient for you. Okay, sometimes the the arthritis is caused by infections. Sometimes. Okay, so if you found anything abnormal and looks like arthritis or synovitis, you should check the medication and the medical history first. Yeah. If there is no medication and no medical histories, and the patient has fever or abnormal blood pressure or heartbeat, I think you should be very careful and maybe refer the patient to another medical doctors. That's another good thing of using ultrasound for you, I think. Okay. Gibbon, 1996, a continuity of the patellar femoral joint. We are going to look at the patellar femoral joint later, very quickly. If there is discontinuity of the bone cortical line, it means a fracture, very minor fracture. The stress fractures in the metatarsal bone now at the NTU hospital is routine checked by ultrasound because it is so tiny. Okay. But in case you find the an image like this, when you are using your ultrasound to screen the fracture, proximal, distal, tibia. If your patient complain a shin pain, and you use ultrasound to look at his tibia, and there is a gap in the tibia, or tiny gap. Okay, and you do not know what's wrong with the imaging. Should it be a stress fracture or just a variation of the bone? Check the periosteum. Yes, you are going to look at it again as well. If there is a thickening of the periosteum, this is a bone injury. Okay, and they use color Doppler. Sorry, power Doppler. If there are some blood cell inside, that's active stress fracture. So weight bearing could cause severe pains without the patient feel the pain after exercise. Okay, with the patient feel the pain when doing the exercise. And in this stage, immobilization is required. In this stage, X-ray need to be prescribed to confirm the depth of the fracture. If it's okay, right? Use the diffusion massage. But because there are a lot of pain receptors in the periosteum, so I don't know. Other which are may can comment. Do not use diffusion massage from the vertical directions, right? Use these directions to reduce the hypertrophy and the sensitivity. Thank you. Of the hypertrophied periosteum. Okay. Cool. Right. Vessel. We skip this one. Now, we going to look at the anterior knee. I think the most pictures about today's lecture about the knee is this one, anterior knee. In this position and the window, we need to learn how to look at the quadriceps tendon. 3-layer structures coming from rectus femoris, lateralis, medialis, interval. Okay, 3 layers. But don't push your machine too much. If you cannot see 3 layers using floating scale, try. If it's still not working, it's all right. Get some money. And the suprapatellar recess. Okay. If there is any effusion in the OA, this shape will going to be changed, become a pool, very big size. A colleague of mine, she used the short wave, the deep heat agent. She found movements of the short wave reduce the size of the suprapatellar recess. Okay, basically, the physical agents reduce the knee swelling. Okay, and prefemoral fat, and you are going to turn the probe 90 degrees. Look at the patellar femoral joint. Okay. You don't need to worry about the positioning because I try my best to write the detail on your slide. If you want to review the detail about today's practicing, you can just look at the slide. Quadriceps tendons, longitudinal view. Suprapatellar recess. Okay, there is a story about the suprapatellar recess. It's like this shape. My ultrasound teacher told me it's a waiter's hand. I think he's a very nice guy, but his life is very boring. So he tried to remember a lot of imaging with something not very close to life. Yeah, I don't believe he watched the beginning every day. I don't believe it's in England. It's freezing. He told me this is a waiter's hand. Yeah, but my English student, my English classmate told me it's a dancing hand. Whatever. Right. 3-layer structures. Then you are going to, the staff at the Mahito can also practice this one. Longitudinal view, transverse view. In the transverse view, you can see the curvature of the VNO medialis and the latialis. Okay. Why we need to look at the curvature of the medialis? Because the medialis is a very unique muscle. It's curved. No pronation angle. No pronation angle. Okay. According to my limit experiences, the curvature become very sharp in the people with knee problem. But people who have no knee injury or no patellofemoral symptoms, the curve is quite, the radius is very big. Okay, the radius is very big. People who had the problems, the radius is very short. And you can find the curve easily, believe me, easily, and they use the software to calculate the radius easily, and they write an article easily, believe me, yeah. Okay, I was told there are half of us teach at the university, right? There are half of us are teacher and teach at the university. You probably have some pressure from the university to write an article or do research. That is a very good topic. Okay. So this is another example of a quadriceps tendons. Okay, another one. Okay, this is a case of knee swelling. It was a waiter's hand before, but now it become this one. So it's a very big arm. It's not waiter's hand anymore. Okay. If the quadriceps is ruptured, okay, the textures of the quadriceps tendon in the ultrasound will reduced or interrupted or disorganized. I think some of you may not have the experiences with the quadriceps tendon ruptures in your patients, but I do have two. They are weightlifter, and okay. So, you know, athletes, they need to travel in different countries for competitions, and some countries, if provide physical therapies, they provide very few physical therapy for the athletes. The people who give therapies to athletes are medical doctors, and in some countries they like steroid very much. Okay, two cases in my clinical services, they are athletes, and they have steroid injections in one country. I know the country, you know the country, but I don't want to say the country now because there are some problems in that country already. And they come back because without any medical records, and they keep their training, and they got ruptured quadriceps. Yeah. Basically, we have to start high resistance trainings 7 to 10 days if patient or athletes get a steroid injection. And they got 2 or 3 shots on the patella tendons. So, and the whole national team were not informed and aware of this. So he continued his training and he got ruptured tendons. It's sad. He stopped his career. Okay. Patella fractures. Some people falling on the ground and landing with their knee, and they have a tiny. They have a very painful knee, but they usually tell you, "My pain is here, my pain is here," and everyone trying to palpate. It's very difficult to find out the locations. Okay, use ultrasound. This is probably just 1.2 millimeters. But for ultrasound, very easy. And see, hypertrophied periosteum, right? Right? Gap, hypertrophy, a sign of fractures, patella fractures. The same windows. If you found the fluid, okay, it's made suprapatellar bursa or suprapatellar bursitis. Infrapatellar bursitis or prepatellar bursitis. It's a lot of waters. Okay, so easily to be found by ultrasound. Okay, then review what we told just for the supraspinatus tendons. Sorry, quadriceps tendons. 3 layers. Waiter's hand, fat. Okay. Then, if you, sorry, it's a mistake. It's too early. This appeared too early. Okay, then 1090 degree. Check the patella femoral choky. It's a groove for the patella. Quadriceps tendons. Cartilage. Okay. The probe was here, then 1090 degree. Probe is here, 1090 degree. Okay? See the groove. That's the quadriceps tendons. This dark area is the thickness of the cartilage. Again, cartilage. Okay. Who are the richest guy in this room? Well, richest guy. Professor, I know Ajahn Pucha is very rich, but we are not going to ask him to answer the questions. So, okay. So, who is the student of Pimon Gong? Who is the student? Who was this? Okay, good. No. Who was the student? Okay. Who was the student of Pimon Gong? No? No? Who is the student graduated from the Chulalongkorn? Cool, it's you. If you saw a patient came with this imaging, with narrowed cartilage, and she is about 65 age, bilateral knee pain, the gait is abnormal, valgus, the Q angle is very big, and he told you he has a history of osteoarthritis, and you think the narrowing of the cartilage is related to the OA, right? Okay, so then I think you will, after this class, you will check whether or not there are spur in this area that increase the patellar pressure, right? Maybe the OA caused the pain, but maybe the pain came with patellar femoral syndrome as well. Good. If there is a gap in here, what question you are going to ask him or her? A gap like this one. If you notice there's a gap, in here, good, good, because chronic pain sometimes, patients with chronic pain sometimes do not always complain of chronic pain because they had falling accidents 2 weeks ago, and not falling accidents make the pain worse, right? Okay, good. So you can use the imaging to adjust your strategy. Okay, floating scale for the patellar femoral ligament. Patellar femoral ligament is a very important ligament. It's related to the force transmission from the vertialis to the patella. And the same important can be used in the medial patellar femoral ligament. Okay, the medial patellar femoral ligament is responsible for transmit the force from VNO to the patella. We often talk about the muscle force, especially the muscle imbalance in the case of the patellar femoral syndrome. But very few people discuss about the strength of the patellar femoral ligament. It's a gap in the research, and also it's a gap in clinical services. Like you look at the tendon, and without looking at you look at the muscle without looking at the tendon. If you want to know the balance between the lateral side and the medial side, and especially discussing some topic about the patellar femoral syndrome, you have to look at the patellar femoral ligament as well. Is it strong, weak? Okay. Then we look at the retinaculum. Okay. Oh, sorry. We look at the suprapatellar recess. There are some fluid in here. So that means you are looking at the suprapatellar recess. If there is a fluid in here, that's also a sign of knee effusions. Okay, so I'm going to show the positioning to you, and the staff from Mahidol University will help me to demonstrate. Okay, so I need, okay. I need a guy come here to help me. Okay, cool. Yeah, just sit. No, okay. Yeah, move it, yeah. No. Move the table to here. Yeah. Okay, thank you. And you sit. Take off your shoes. Yeah. And turn 90 degree. Sorry? No. I just demonstrated the. Okay. For the quadriceps tendons, probe. For the patellofemoral joint, turn 90 degree. Move to the distal of the quadriceps tendons, turn 90 degree. Okay, and found the superior border of the patella. Thank you. You remind me. Thank you very much. Okay, then this is the degree about for the medial patellar ligament, and this is the angle for suprapatellaris and the retinaculum. Okay, so your job is 1, 2, 3, 4, 5, 6. Okay, stop. A break. Okay, stop, break. Yeah. We come back 11 o'clock.